Done.
That's recording, correct?
Yep.
Yeah. Well, thank you so much. Okay. Look, welcome to the International College of Dental Practitioners, probably the first of the webinars and Q&A we're conducting on behalf of the college. And one of the important things that we like to do with the college is share the knowledge. I've been fortunate enough to have the presence of my colleague, Adjunct Associate Professor Mehdi Rahimi, who will be an expert endodontist in this discussion. This is a Q&A, and the most important thing in Q&A is to encourage participants to ask questions, and we have to answer them, and to show you how do we look at cases from the specialist point of view, and share ideas in our thought process, and most importantly, in terms of how to encourage the concept of think like a specialist and work like a specialist. And we're going to go in terms of 6 webinars next few weeks, and the titles were presented initially. And those of you who like to connect with the college, Instagram's our page is there, and you can just join the college later on. But nevertheless, we're going to go 6 webinars. One is what does it mean to lose a tooth. This is today. And then we're going to lose crown, which just talks about how to restore the missing teeth and the problems that's encountered in terms of losing anterior tooth, especially in the high anesthetic zone. And in terms of when we talk about teeth wear, an adult patient presents in your practice, how can we have a simplified method of providing this patient improved aesthetics and function? And nevertheless, that same thing is applicable to someone who's in his 40s, comes with worn teeth. What's interesting and safe as a middle intervention way of restore this patient to normal function and improve aesthetics. Coming to the 5th one, it's talking about the options of replacing lateral incisors. And I think there's a lot of ample research today that indicates that implants are not the first option. There's other options. And we have long-term studies on this that tells you that it's minimal intervention. It's easy to do. So I've been discussing in number 5. And naturally, I think simple cases like managing white spot lesions and conservative management, non-invasive management of white spot lesions. The aim of these next 6 seminars is to be able to present the topics and cases that come in your practice every day. And the most important thing of coming to practice every day that your patients present, because there are simple cases to think about, how do you treat them, and what critical decisions you need to do. And naturally, we are here to help you in achieving an optimal outcome for your patients. So without much ado, I think we should proceed with our case. Here's a female patient presenting with 2 fractures, as you see, 2 weeks post-trauma. And we're going to do a comprehensive discussion of this topic. We're going to discuss how do we achieve diagnosis. The most important thing about achieving diagnosis is what tests do we require. And we're not going to talk from dental point of view. I think we're going to look at other aspects as the patient, as a holistic approach. And we'll talk about treatment options, etc., both short-term and long-term goals. Well, I would like to ask any of my colleagues in terms of what questions would you like to ask this patient in terms of when it presents in your practice, and what do you see in this particular instance with this patient? Would anybody like to comment? Well, let me help you. Someone can. I'm happy to. If anyone wants to comment, I think I'm quite happy to get your opinion. So I can unmute you, but we'll let you go. But the way I'm seeing this patient is what I'm seeing is I can see, for instance, there's a fracture of this teeth. And it tells me probably the direction of this fall. So I'm not quite sure if I'm looking at this stage where tooth number 1 has got a fracture as an intrusion. I definitely know that there's a fracture of the tooth number 2-1. And there's quite a complicated fracture of tooth number 1-2. Is there anything else you'd like to see, for instance? Any other participants like to say? What else do you see that will affect your treatment outcome or your initial diagnosis? What else do you see? Is Vivek there?
Yes, doctor.
Well, what do you see, Vivek? What else do you see?
I can see that it could be an intrusion.
Mm-hmm.
The chances of, I think it could be, there could be a fracture, doctor.
Yeah, it's both fracture and intrusion. And I think you can see the patient had suddenly lost balance and she fell front on. She also had a bruising on the face, which we'll play the video later on. But this, to me, looks like an intrusion. Maybe we should ask Dr. Medius what he feels is a possible intrusion. What would your initial thoughts would be, Mehdi?
You mean the possibility of intrusion?
Yeah, on one.
Well, I'd need to see some radiographs, obviously, to see. I mean, 3D imaging would help, as well as a periapical. Normally, we do 3 different periapicals, so
Right.
like sort of parallel view, shift view, and a horizontal view,
Mm-hmm.
and we should be able to see, for example, tooth 1-1. If it's intruded, it should be, impeding into the pedon ligament space. And I also want to know, if there's any other type of fractures clinically
That's right.
have detected. So have you detected anything else that we can't see from this image?
Exactly. Well, just from this image, my initial observation is I can tell the direction of the force. And so when you have an idea, we can see the fracture of the teeth that's indicated. And the other thing I'm so quickly having a look at it at the same time is the interarch and intra-arch considerations and what would be the possibility of future restoring this teeth, although trauma is number one, remembering that the patient presented 2 weeks after the trauma. And so that's something, I like to think about it. And if you look at the occlusion, the patient is actually in full contact here, but these teeth are basically in occlusion and fractured. So that's a bit of a concern for me as to the amount of heat, the direction of heat that these patients sustain. I guess maybe just looking clinically, you could say, well, there's definitely a fracture here. And I doubt very much if that anterior central was in that binding relationship, but I understand. So we do need the periapicals. Let's have a little periapical. I think I'm just trying to think. Naturally, the mobility of this tooth is more than 3, and there's a 11 mm pocket palatally of this particular tooth. So I did some tests. They're both the lateral and 1-2 and the central 1-1 tested, non-vital. Naturally, it's very hard sometimes to say. I mean, when would you look at doing pulp testing? Would you do immediate pulp testing with a trauma, or?
Yeah, we do. Well, we do baseline pulp testing always, even though many of these teeth can be non-responsive, especially teeth with open apices in younger patients.
So this one's
yeah, obviously this patient doesn't meet that requirement,
right.
but we always do a baseline test, even though many of them can be false positive. And
Right.
we do a review at 6 weeks, usually according to the guidelines, but it depends. Between 6 weeks, depending on the trauma, to about 3 months, we do a repeat pulp testing. And then we, of course, then can repeat that test at 6-month point, even up to about a year, especially in the first 6 months. 80% of teeth can revitalize if they had different type of trauma to the ones that you're describing there in open apex cases. One test that is not done by dentists is a true vitality test, which measures blood supply. And here I'm talking about pulse oximetry. So if you use a pulse oximeter with a small, it's like an ear clip, you can get that. It's a similar mesiodistal dimension to a central incisor of an adult. And you can pretty much fit that onto a lateral or a central and check a true vitality, which is blood supply. Often that test is the most accurate because on day 0, when you saw this patient, or 2 weeks, it'll tell you a true blood supply, because the neural supply can get severed. Most other vitality testing will be with, for example, the ICE testing or the CO2 testing, or even electric pulse testing. Then they're just measuring neural supply. They're not measuring true blood supply. So we highly recommend people that see trauma to purchase one of these pulse oximeters. You know, and they've got to be the ones which fit onto an ear clip or a pediatric pulse oximeter.
And where do you purchase that from?
I can, you know, later on share the link, but where I purchase it from is from Nellcor from the States. So you need to have someone in the States, like, you know, I've got my uncle Turabinijad there, and he actually purchased it for me, and then he sent it by mail address to me. My uncle Turabinijad, I think some of you would know, is the author of Principles and Practice of Endodontics.
Well, he invented MTA, didn't he?
Yeah, he's the inventor of MTA.
Of course, of course. You have a famous endodontic, family line there. I'm very, very impressed.
yeah. So it helps because obviously, you know, I was introduced to the pulse oximeter, and then I could purchase it from the US. That is the one that fits best, and it's the most studied one. So that's why, you know, I know it works. So that's why I would purchase that.
That's fantastic. Well, very good. Thank you for the input.
Nice.
The other thing I'm noticing here for this patient has got an erosive diet. You can see that there's a considerable loss of cervical enamel there, and there's also in some recession, so she's in a thin biotype. And having a look at the thin biotype, I know that should I find a crack line on tooth number 1, and having a most likely intrusion in this case with a directional heat, there's a good chance maybe I might also find some alveolar fracture there. And my gut feeling here, although we can't speak in terms of gut feeling, that if in the case of loss of teeth, we'll anticipate some sort of quite a lot of labial plate loss. It's 2 weeks after trauma and nothing's been done. There's an infection naturally, but there's no lymphadenopathy, and there's a granulation which is forming around. It's a protective mechanism. Now, coming forward there, and I took an X-ray. You can see the position of the 1-1. There's definitely a fracture, but there's a widening of the ligament. It's not a very clear X-ray, I'm afraid, because I have a sensor problem and I have to change another system. But I have the CT scans I'll discuss. But looking at palatally, I mean, what do you feel we see here? I mean, that's definitely
it's an intrusive injury, yes.
It is, yeah, and there's definitely a labial fracture. Looking at the position of it, and I'm looking at it of the labial cortical plate. I sort of looked at a microscope here, and I suspected that something's happening here. So, in terms of, I'll look at, for instance, besides that, I'm looking at the crowding issue. You know, in terms of how do we restore this area? You don't have enough room in the case. If you have a fracture, to place the implant, we'll talk a bit more on that. You know, there's an inflammation and palatal tissue hypertrophy with inflammation. They're all non-vital. So I look at the microscope. You can't see it clearly, but here's a line here, and there's a fracture line there. So I think maybe you want to make, I mean, assuming there was no crack here, what would you consider as a long initial measure of doing a more like a contingency planning and seeing and reassessing? What would your approach would be in this area, in this case?
Yeah, I suppose in many types of fractures, in fact, in crown root fractures, even some crown fractures and injuries to the ligament, so they're luxation injuries, the recommendation these days has changed. You don't just take periapical radiographs, but you also do a CBCT analysis. So CBCT is recommended where you can get a CBCT, and in many trauma cases, it's not a must, but it's recommended, suggested you take a CBCT. So I certainly would do a CBCT test to see both the 1.1 and 1.2 more clear. I'm suspecting that when you did your vitality testing, the other teeth adjacent 1.3 and 2.1 and lower teeth were vital, right?
Yeah.
There's no other opposing injury, right, to the lower teeth. Yeah, because sometimes we miss the obvious. We miss the lips.
Yeah.
You know, sometimes even a fragment might go missing and you can't find it. So if there's no laceration of the lip, because I could see a little bit on that image there, I sometimes take even a 25% of a normal exposure radiograph of the lips and the lower teeth, and I test everything else. Then I go, okay, I'll zoom in onto the 1.1 and the 1.2 and a CBCT. Analysis will be done here. I'm looking at the closed apices of the 1.1, and from the judgment of you're seeing a crack there that looks subgingival, possibly subcrestal there. I'm saying the prognosis for 1.1 is poor. And then, of course, sometimes in these cases, we enter the pulp space in these cases and put medication down the root canal, because the tooth in an intrusive injury 100% would have devitalized, and almost 100% of these cases will undergo eventual replacement resorption. And the main reason why I get in is to stabilize, medicate, maybe get some, maybe get the infection under control. Hopefully the gingival area and periodontal status will improve with some debridement periodontally, as well as intracanal medication. The other option is obviously extraction. So I'll leave that up to you straight away, because you obviously would manage a lot more of these cases. And sometimes you may opt for extraction.
Yeah, well, my first option is to get you have a quick look at the situation before we make that decision. But patient is just arrived in Australia, and that's one of the important decision factors. And finance, employment, and when I explained what we need to do, and it was like prolonged treatment, what's the safest option? I said, look, I know 1.1 has got a very poor chance. And she's being very traumatic and a lot of issues. I mean, I'm just going to show you the other cases. We got the other slides, for instance. I mean, when you look at this particular patient, you'll see she's got a moderate to high smile line. And she's a young lady, a very attractive girl, but she's highly traumatized and wants immediate solution. There's definitely more mobility, mobile free. This is just breathing in the air. You could put a probe all around, and now we have a static zone, and I need to think, well, do I maintain this and maybe have a further tissue loss, or do we take our chances and look at the type of teeth, triangular? So all these things are going through my mind. As do we have adequate support? How do we get this patient's confidence back? And she's completely shattered. She mentioned to me that tooth was loose. She stuck it back in, didn't come out, but she pushed it back in. So most of these things tells me that it's going to be very difficult for me to probably save this tooth in the long run. And looking at all the situations, I thought, maybe we might end up losing this tooth that would give me immediate time to restore the rest of them and maintain, and then be able to reassess the vitality of tooth number 1.1 and also 2.1 in the near future. I'm not sure what happens to 2.1, whether it will be vital at this stage or change. It's hard to tell. But looking from the prosthodontist point of view and looking at the whole biology of the situation, I said, do you have your teeth that you had before? So she had the iPhone, so looked at the iPhone, got an idea where the teeth were. That was good. I haven't got the photos with me, but most people have their smiles on their iPhone, so it's such a good tip that you can sort of let me look at the photo. You can compare it, exactly as you said. Maybe it is an intrusive fracture. It's quite a large intrusive fracture and intrusive intrusion of the trauma and of associated fracture of the crown. But nevertheless, I anticipate there'll be a lot of hard and soft tissue loss, so patient will explain. But her main thing is to get back to normality, and she thought they should split 112 out completely. Well, you want to see the cone-beam CT,
Yeah, that'd be
so
good.
let's look at the cone-beam CT, and you can see that's floating in the air. There's definitely fracture of the alveoli, both labial cortical plate and palatal cortical plate. And looking a little bit more, you can see this is tooth number, I think is 111, and this is a intrusion, and it's been a trauma. It's been trauma there, and it's come loose again. I think that direct heat, you might think it's probably inflammation causing it. It's possible, I'm sure. But I can just see that it doesn't happen so quickly. I mean, how do you feel? There's a bony outline sort of bent there, and it's not like that in the normal X-rays. I don't see sort of that angle.
Yeah, it could be the impact of trauma.
Could be the impact of trauma, couldn't it? That's right.
Yeah, yeah. Because usually you don't get a lesion that size within 2 weeks. That's pretty impressive if you do.
That's right. Well, you know, I'd like to sort of get in there and have a look, and at the same time, patients looking at the images, but it's a good idea to get their self-consent. Here's a panoramic image taken. You can see the position of the tooth in the same line. There's definitely intrusion and the involvement of the nasal floor. Well, there was something else I thought we're going to look at, because, you know, what about if she had the direct hit, maybe as a laceration of the chin, but, you know, I like to check to make sure that there's no trauma to the temporomandibular joints and there's no evidence of trauma. And further X-ray shows there's some, she definitely has, I guess, oral hygiene problems. You can see the area here, and past the canal therapy. So that's secondary. We're going to get this patient into the comfort zone, and then she's in a position to think. Is there anything else you want to comment here? You're okay with this so far, maybe?
No, it looks good to me.
Okay. Well, that's a bite that was taken. We know that 236 has got guard prognosis with poor therapy and pulse seal. But again, patient promises that come back and never, have the rest of the condition treated. Well, there's story behind that as well. And naturally, here's our patient. And, behavioral X-ray, so I need to do a specific risk analysis, and the patient needs to understand the problem. And don't forget, they're crying at the same time. You can see the tears running by. And I had to take this photo. I just had to take it so I could look at position of the occlusal plane in relation to the face. This is very important to me, so I can in the future know where I'm going in a particular case. And we, look at, there's no medical compromise. I mean, apparently she has a high state demands, and that needs to be modified and spoken to the patient. Smile line, thin biotype, and the occlusion risk factors, they're always unfavorable for these patients. So nevertheless, we have problems, but most important thing we need to fix for this particular patient is her biopsychosocial status. I mean, what I couldn't understand that she's been hit with the trauma, she's in a shock for 2 weeks, and she presents to the practice and during that time. So, and what I like to see is the fact that we need to give this girl a hope. And most importantly, I'm basically trying to help the patient, help the patient to regain confidence, and so that is an important part of the overall planning, I presume, is to, how do we go and immediately improve this patient's aesthetics and give her confidence back? Well, what we did for this patient particularly is that in this particular instance, we had to remove the tooth. And let me just play the video at the moment and just see what she says. That's the initial presentation.
Okay, I'm recording you. Tell me what's your main concern.
My main concern is 2 weeks ago I lost balance and I fell face first from the flight of stairs, my teeth and have some bruises over here. So yeah.
Big smile, really big.
So she's not obviously in any pain, okay, and there's no real infection. So, I mean, would you prescribe antibiotic cover for this patient, Mehdi?
No,
No, absolutely not.
no. Antibiotics prescribed when necessary, which is often when there's fever, malaise, and cellulitis. And occasionally I do sort of prescribe to, they can keep it with them in case of that situation, you know, occurring.
Yes.
I certainly ask about where the injury occurred, because if they fell and, you know, the tetanus is not up to date, I would say, okay, tetanus update necessary, things like that, immunizations up to date. Or a booster. But at the end of the day, antibiotics often is overprescribed in these circumstances, and I would not advise them to take it. They'll keep it in case there's a cellulitis, because there's a crack, and eventually, you know, bacterial infection can lead to, you know, very rare occasions, you know, cellulitis where an antibiotic is necessary. And often with the antibiotics, you need to do either extraction or intracanal medicament placement. So you need to eventually treat the cause.
Absolutely. Look, maybe we did immediate fiber reinforced bridge replacement and bridge restored in South Regis, and
That's amazing. Very good
that was
result.
only one visit, and she hasn't seen the case, obviously. But as I said to you, I think sometimes you have to sort of bite the bullet and say, what's the priority in our case? And I think priority was to restore this patient's confidence, get back to, you know, enjoying her part in Australia. She did. She's a very pretty girl. Big change from when she presented, and I think sort of, you know, I think she's pretty happy. She hasn't seen the work yet, so it's just interesting sometimes. Just doing very simple dentistry will really help our patients gain confidence. So, and so, you know, she hasn't seen the case, and it changes people.
No way.
Okay. Anyway,
That's an amazing result. Amazing result.
Yeah, and we managed to, we changed people's lives, but nevertheless, patient didn't come back for 12 months. So this is what happens. Doesn't come back 12 months, and I sort of had to call the patient as I was planning to do these webinars, and I said, "Well, I haven't seen you." Oh, she said, "I'm very sorry. I should have meant to see because my bridges come loose, which is always the way." So she comes in, a slight mobility of the bridge, but not too bad. A lot of bashing for Freeman. You can see the composite wear, etc. But we have sort of lost labial, labial cortical plate. But if you think about it, we haven't lost sort of a lot of height for this patient, which meant that the palpable bone is very stable. It doesn't restore very easily, and this is a good thing. And so by allowing a favorable environment, in other words, having the ponte to support the tissues, and having no loading on the tissues. So since people say, "I use a partial denture," it's probably the most wrong thing to do. Because if you place a partial denture, you'll definitely lose those tissues. And using simple, FRC, bonded bridge work, fiber reinforced bonded bridge work, will do wonders for some of these patients, just a simple composite repair. If we maintain these patients, just with chips, etc., and that's easily fixed. That doesn't take long to do. But we managed to look after this patient. There's been a healing palatally, you can see that, okay? A few rough margins, so there's a lot of bashing, obviously. And we'll manage to clean, do the general prophylaxis for this patient. But overall, we lost a papilla. That's from a trauma. There was a loss of bone on middle of the 1-2 on the right side. You can see it here. But we're still in a position to, reconstruct this patient. The trouble is that it's all very easy to say, do we place implants? Because placing an implant in this particular case, it really would be a disaster without doing orthodontics and improving both the arch width, inter-arch and intra-arch relationships. Nevertheless, when I thought of the case initially, I thought, well, this is not too bad. It was a lot worse than I anticipated. But obviously, she's being young and a good regenerative capacity and non-smoker. It's done wonders. So one important consideration we need to have a look at it from overall management point of view is that when we see a case, we stabilize the control phase. We stabilize, control infections, improve, to improve the restorative outcome. You do your prophylaxis. You discuss with your patients the maintenance protocol, because a lot of work's done, especially dental implants today, where a dentist just wants to place implants, but does not discuss the maintenance protocol. And this was discussed very clearly with the patient. And we stabilized the patient, and we went through the diagnostic phase. So we really on the diagnostic phase so far. What the diagnostic phase really means is that we're not just diagnosing the fact that we can place implants or we can do orthodontic treatment for this patient, improve the arch width, form, and space, and how much grafting we require. But the most important thing is we're going through a risk assessment. We're testing this patient over a period of time where they're good candidates for further, more complex restorative care. And the patient is not, failing to undergo the basic, control phase, which is scaling, cleaning, root planning, just maintaining the existing teeth in good shape, then I think going to definitive restorative phase in the treatment is definitely contraindication. I see you many times you reassess the patients that have complex root canal therapies, and some of the work that I do is amazing. I think, especially when you find the fifth canal, let alone your MB2 on your car plate, but you find the fifth canal. To me, that's really amazing, because I thought I only had fifth canals and nobody else had fifth canals. And then maintenance. So the maintenance protocol should start from the beginning, not at the end. If the patient in my practice can't commit to this at the beginning, I will not start the treatment. I will basically do a remedial treatment and that will be it to help the patient. But having said that, let's look at 12 months post-op without taking the x-rays. Let's look at this patient. Here's tooth number 1, 2. It's developed periapical radiolucency. It was non-vital, so it didn't really get better, obviously. So that needs root thread, and the patient will be seeing you hopefully shortly. And looking at a periapical view, we have lost some bone at different angles, but that needs to be restored. Rest of the teeth are vital, it's been tested. And I'm sure you'll do more testing for me when you see the patient. But although you might feel we have adequate room to place implants, I'm not comfortable placing implants in that position unless we have to put the 1-1 into more anterior position. And looking at side 1-1, you can see amount of bone that's regenerated. And this is a beautiful space-forming defect. So I can easily graft this side because I've maintained this part. You can see that the swelling is almost gone. But this is easily graftable because we maintain palatal bone is very resistant to resorption. So we can obviously graft this area. Well, it always pays attention to do some measurements, and we have 5 by 16. I can add another millimeter or 2 here and build a whole area. So an implant will be positioned so it comes up with a cingulum. It's been screw retained, implant supported prosthesis, single crown. And you can do trial, and you can see that you only have to graft one of the 2 get. So it is a predictable situation that we have been able to achieve for this patient. And would you make a comment here, Manny, in terms of how do you feel about so far?
Yeah, look, I'd say I agree with potentially, if the patient can afford it, realignment of the dentition, getting a better, as you said, intra-arch sort of outcome prior to considering placement. But if the patient affordability comes at stake, then I definitely would recommend endodontic therapy of 1-2 prior to any grafting and prior to any implant placement in the 1-1 site. I also, some people talk about closing spaces and performing orthodontic therapy. The things I look at there are the mesiodistal width of the lateral compared to the central. So here, that may be somewhat favorable compared to other laterals that might be thinner. However, I would also be really worried about that high smile line.
Yeah.
And the fact that you said that she's got a aesthetic demand, reshaping teeth and moving teeth in, would have their own issues, obviously, with black triangles and things not looking right. So I would be more driving the patient towards a dental implant if you think that, you know, you can also meet the cosmetic need of the patient.
Well, you see, that's right. I agree. Look, we need to graft here, and we're not going to get rid of this black triangle on the right. We're just not going to.
Yeah, okay.
It's just not going to happen. I mean, people pretend they can, but it's not going to happen. So that'll be a prosthetic replacement. So she needs to understand the problem in terms of what the limitations are. I think the other option, other than implants, we can consider a resin molded bridge work here as well, and that's a less expensive option for her. Still less invasive. That can be bonded. You know, this is one non-vital one too, so I wouldn't consider as a good abutment. But one too, we can consider provided occlusion is favorable. In her case, the occlusion is unfavorable, so it's very close by. It's impossible to do. So from the point of view, I think implant replacement and grafting labial deficiency will be more indicated. And one of the reasons we will graft labial deficiency here is because this area here on the right left side is convex, it reflects light, and this is more concave. Now, what really precludes the problem here is the fact that she's got a dark genetic and ethnic discoloration of the gum, so that makes it even darker. So aesthetically, it's very, very complex, and the patient needs to understand that. So we need to graft this area and make it more convex to allow proper light reflection. So to be able to develop the proper versions of the crown, naturally implant will be placed in the right position, but the crown emergence profile needs to be correct based on the labial cortical concavity that will also perform the bone level. And I said, how to say that tissue is the issue, but bone sets the tone. I think it's very important here. You can thicken that by doing connective tissue grafting, etc. That's all very well, but we do need the bone to support the tissue. And naturally, we will need connective tissue grafting in this area as well, which is a normal part of the process in this case. Coming back to this, I think maybe we discussed some time ago, and we said, this is 1 year later, I just did some polishing of the bridge. It's the same patient, completely different person, as you can see. She's a very pretty girl. But the problem still remains. I mean, this is composite, just resurfaced, pre-bonded to 1-2. I don't bond it to 2-1. There's just no occlusions extremely unfavorable. So we are still, after 12 months, in diagnostic phase. And I'm afraid I can't do any further other than doing the root therapy or distressing here for the time being, because she's back and forth, and this is COVID at difficult times. And 1 year post-op, I presume the take-off message would be, and I'll say a few points, and maybe I would be grateful if you add yours as well. In terms of, I think we need to simplify complex problems, understanding that if you did immediate implantation for this patient, firstly, it wouldn't work. There would be a lot more bone loss, a lot more tissue loss. She would be a lot worse than before. And in many ways, we try to improve this patient's confidence. That was the key to the treatment outcome. And that is the initial treatment outcome. We have a happy patient who has developed a trust with a specialist or with a general practitioner, and they will be more amenable to treatment suggestions and think about future care as well. When you think about, she's got a very narrow upper arch, she's got anterior 6 members showing, although that may look really good for her now. So if you decide to place the implants, what I need to do is that I do a special digital setup or a digital castling setup where we can put the teeth where we feel. I can put the implant predetermined with a special surgical guide in the correct spot that will not only give me a good outcome at this stage, but also be in the right position for a future arch development should that become necessary. And that's a very important part of the consideration as you plan ahead of the game for our patients. This is one important part, is as a specialist, we always look at maybe that there's many ways of looking at it, and at least keep our options open. And that's one of the key, I think, part of today's Q&A is have your options open, have a contingency planning. You need to have a fallback situation that you can do for our patients. The second thing that I thought was very important is time is on our side. We will do root therapy here, that's fine, but we have time. You know what I mean? She'll come regular care, she'll stay within the practice, and when she's ready financially, we can repay this provisional bridge work many times, and that's fine. And then we're able to look after this patient. The other thing was that I think this is more important in giving advice to my general practitioner colleagues is the fact that you do not rush into definite treatment so quickly, because what really happens is then you don't have a fallback situation. So in our case, we have a fallback situation that we can go back in and really cement this provisional bridge work for many times until the patient is ready. And the patient will be ready at some point in time when she's ready to move into a bigger and better world. Now, we as practitioners should be able to help our patients to integrate into society and improve their quality of life. I'd love to have your comments, maybe, if you like.
Yeah, look, I agree. Time with trauma is on your side. The only time I suppose I'd need a review is if a tooth like this, or in a younger patient, I suppose, more importantly, has become non-vital, whereby inflammatory resorption can occur a lot quicker. And so I just need to review the tooth and make sure if the tooth is non-vital, we could at least put some intracanal medicament to avoid inflammatory resorption, which can result in loss of quite a bit of root structure, and is manageable with just intracanal medicament, chemomechanical disinfection and medicament. So that's the only thing that I would watch for. Definitely with the definitive treatment planning with a case like this, which is very complex, I would always be, getting specialist opinions, and gone are the days where the general dentist will only be in a format of writing to I suppose to different specialists. I think these days a phone conversation and specialists being more approachable, especially with cases such as trauma, where upon immediate management you may need to act quickly. I actually share my not just my contact details, even my phone number, with those dentists who may need to discuss the case on the spot with me. If I'm within the country, I say to dentists, I'm always available for a discussion, even if they decide to send to another endodontist or to another specialist. But I certainly think you've got, the days are different these days, and you can definitely communicate with different specialists. And in a case like this, even if you get an opinion and you actually do the management, I highly recommend that you get an opinion, because there's also, especially in the Western world, especially in Sydney, highest suing rate in the world right now. We've passed San Francisco. So I would recommend that you have everything in writing as well as discussions, and you note everything down. Your record keeping and your record taking at the instant of trauma, just like Sarkis has done here, and the number of photos that he's taken mean a lot. With trauma, I highly recommend you take as many photos as you can, and you don't go by the principle of ALARA, which is as low as possible radiation. If you can get your hands on a cone beam CT, do that. Don't forget your pulp testing, add the baseline test, and don't forget to test everything lower. If it means a two-dimensional image of the lower teeth, pulp testing the lower teeth, even taking in a radiograph of the lip, soft tissue if there's a laceration. So you cover everything, cover all bases with your record keeping. That's also very important.
Very important. And one of the important aspects of, you mentioned about writing a treatment plan to the patient, is when you write the treatment plan to the patient, some of our colleagues have a treatment plan, it's basically quotation. And it doesn't mean anything, because, and also a lot of the times, let's say the implant therapy, and I get a lot of those second opinions to give opinions on those. And I asked the colleagues to look at, we'll talk about a bit more in the next sections on implants. where I said, well, where's your consent? And he's giving me this, you know, the ones that RCOI has published, like it's to save you under anything under the sun. And the patient consents. You know, it just says also silly things. It's nothing specific for that patient, for that particular site, for wherever it's been to be done, and doesn't mention the rationale behind treatment. And sometimes I have cases where I have to ask my colleagues, look, I don't know, tell me, you know, the rationale behind your treatment. Why did you treat in this way? There's no sometimes real explanation because I only know one way of doing it. But that's what I'm saying. Contingency planning and just doing something even temporary, minimal intervention, getting patient out of pain, getting a second opinion, and just rethink the situation. Get your favorite colleague on board, you know, specialist colleague, just to explain, look, have you looked at it this way, have you looked at it that way? And then you feel, wow, I didn't look at that. I'm glad I had a couple of guys on board because people are really happy, and you know, they're happy they got really good team support, and that's really important.
Yeah. And I guess remember that if you don't take your time with cases such as this, apart from, of course, immediate management being an important phase, unfortunately, in today's world, a lot of people will critique, and a lot of things can go wrong with trauma as well, and mismanagement of trauma, especially in the younger age group. So I think that's why I highly recommend you refer, at least for an assessment, and I suppose recommendations from the different specialists. And one of the issues with a case like this is also the patient needs to decide, because in some of the areas, which is a gray area, or there are alternative treatment options, the patient needs to get involved. And sometimes, unfortunately, in the world of dentistry, we have bias towards a certain treatment that we may be better at doing. So it still is better to sort of leave the camp open with no bias for the patient to decide, especially in the grey areas where they've got a few treatment options, orthodontic silly being one of those options, apart from implant replacement.
It's interesting what you just said. Can I just add on to that? And thank you so much for that comment. Now, this lovely girl, she still doesn't understand the complexity of a treatment. She still doesn't accept that this is not a simple case. And I said to her, until you understand how complex your treatment is and accept and comprehend the situation, I cannot treat you. So, and we left her at that, and I'm writing a referral for you to have a look at the patient, and she can't come in, and I'm trying, but this is a problem we are faced, because people think it's a simple case, and she says, go to another dentist who actually is happy to grind the tooth in and put a bridge. I mean, even today they do that. I can't believe it, but it's happening. And I mean, this was overseas. If there was no COVID, she'd probably fly to somewhere, Bali, and they would have done that for her, or place some mini screw in the middle of the tooth that you can get from Bunnings and place them. But that's not how it's done.
Or a snap-on smile or something.
Or a snap-on smile. Totally damaging teeth, or a partial denture will damage your teeth. And so I'm actually seeing a lot of patients now that have treatments half done overseas who can't go for a year or two. And it's astounding what you see that comes across to your practice. But nevertheless, look, this is the last slide, I believe. And any more questions from any of the participants that I would like to say?
Is anyone there? Just joking.
Okay, there's a few of them.
Yeah, there's a few still there.
Yeah. Okay. Well, Prudential Dental Clinic. Any questions I have, my friend?
Yes. I just need to unmute myself. Okay, can you hear me?
Yeah, I can.
I just have two questions. The first question I'd like to ask the endodontist. You talked about intracanal medicament. I would suspect that you would put odonto paste, correct, if you are treating?
No. I would actually recommend intracanal medicament calcium hydroxide. It's antibacterial, and it's 2 weeks post-trauma. I would only use something like odonto paste, or of course Lenimix, which is back, which is an anti-inflammatory, if it's at the time of trauma. if we knew the tooth is, for example, closed apex, avulsed, or of course severely intruded and closed apex, we could get into the root canal system, and then the medicament of choice would be something that has an anti-resorptive activity or anti-inflammatory activity, such as odonto paste or Ledamix. But 2 weeks post-trauma, we want the maximal antibacterial efficacy, and that's why calcium hydroxide is the recommended medicament of choice. And of course, we know that it can remain as active within a month post medicament placement. I also like calcium hydroxide because I can actually take a post-op film, and I usually place it with a Navi tip so I can measure it a mil short of my working length. So I know I've addressed where necessary within the entire root canal system. I can take a post-op film and see that I've placed the calcium hydroxide appropriately. So calcium hydroxide is definitely the medicament choice here.
But won't it augment the chance of root resorption?
No. It happens, as I said, within the first few weeks. So after that, no, you want something that's the most antibacterial. But within the first 2 weeks of trauma, or within the first few days of trauma, if you like, then an anti-inflammatory medicament is the recommended. And in fact, sometimes what happens is that you place your anti-inflammatory at the time of trauma, and you go back and you want something that's actually antibacterial, that actually we know is the most antibacterial. Lots of medicaments have been studied, and calcium hydroxide is the medicament of choice.
Okay, thanks. A question for you, Dr. Nalbandian. You mentioned it took over a year, but if there has been infection around that area, I mean, we are not leaving room for infection to settle in, right?
Which is
that
the area 1-1 area?
Yeah, 1-1, even 1-2, right?
Yes.
And if you had to go back to implants later on, would it make it much harder to get good quality bone?
When? After a year or?
Yeah. I mean, wouldn't that be better if you had dealt with earlier on?
Interesting. Well, let me put it this way. I would say, and Mehdi can correct me, it will take about at least 3 months to get this area minimal. And now there's a good 6 months is an area there, so that takes time for this bone. I mean, having a non-vital, Mehdi, would you consider as non-vital trauma just the root therapy, or would you wait for something to develop?
In some of these cases, if I decide to medicate the tooth, and I believe I've done a, appropriate job. I mean, this is a fairly simple root therapy.
Yeah.
As long as you seal it well and you medicate it well.
That's right.
I wait maybe 3 months, and I know within 6 months, 50% of cases will completely heal. So within 3 months or 2 months, I should see radiographic evidence of healing.
Yeah.
And so I would review it within 3 months and then advise you're ready to do your implant.
Exactly. So that
So
would
even if I medicated, didn't obturate, let's say, I can still let you go ahead as long as I've had radiographic evidence of healing.
Of course. I mean, naturally, I mean, this is 2D, an implant with a different position to what the apical area is, and we know that. But to answer your question, did you expect me to place the implant immediately?
No, not certainly not. But I'm more. I mean, did your decision determine whether because there was a palatal did you say palatal bone alveolar fracture?
Well, she hasn't turned up 12 months. That's going to be so.
Oh, okay.
So, and I accept your question. What I would do is that within 3 months, we know where we are. And if you look very carefully, this is the trauma area, basically, your root palatal bone. So 3 months would be enough for me to, this bone probably would get to this age about 3 months. So any little change will not measure after 3 months because your labial cortical place disappeared. It disappeared within the first couple of days. So having said that, also don't forget, also 3 months gives you good tissue maturation. 6 months gives you better. But I'm not really worried about that. She's here 12 months as her hair, but you have a good tissue now to be able to build, the site. So 3 months will be the least amount of wait to be able to go ahead and look at initially restoring the root canal therapy 1-2, and then look at the implants. But again, she has to sign off the fact that she refuses root canal therapy, the orthodontic treatment. She has to sign off that she refuses orthodontic treatment because she has to understand that, because that's an important part of the treatment plan. Because years later, when you place the implant, that part of the bone no longer remodels, it stays there. Okay. The bone remodeling process, implants don't preserve bone, right? Like bone doesn't give a stuff about implant or not. They just bone restore what they want to restore. We know that. And the most important thing is that if the later on patient has other issues such as aesthetic issues, etc., and you haven't enough room to sort of build your labial plate, and you haven't got good relationship with the bone, your crown is a bit more forward because that is inadequate intermesial width, then obviously that will be an aesthetic issue and that will complicate treatment. So she needs to understand that. She has to sign off that she refused orthodontic treatment. That will be prerequisite for me moving forward.
But do you think that 1-1 is a good site for an implant? Is there enough?
Personally, no, because I'll show you why. Okay, there we go. That looks good because I place the tooth and I build this, okay? So if you see the width of here, mesiodistal here, it's a lot bigger than that, okay? Now I could make the lateral a bit smaller, but don't forget this lateral is angled. So it's a width problem. You're not gonna get aesthetics right. I've only got the aesthetics here right because I've overlapped with the lateral, unless she wants to have it the same now with the implant. But that's not that simple. So she has to sign off on the fact, because as time goes on, let me explain to you that how the jaw, I know she's in the mid 20s, 26, 27. So with time, this crown will get worse. The upper arch will get more narrow as the aging process. When she's 40, she's going to come back and say, I want orthodontics, or I want more work. And there's always implants stuck there, I can't move anything. So your implants to be so perfectly placed, and you have to do the feasibility studies that hopefully last more than 10 years, that it has to be the right place so the resorption won't have a problem, there'll be no defect, there'll be no hypoocclusion. There's a lot of issues here that has to be explained to the patient. In the aesthetic zone, be always careful when you place implants, not because you got immediate good aesthetic result, but how does your work look in 10 years' time? Because jaw always changes, okay? It changes. Most of the change happens in women from the start of the age of 38 onwards. For men, it's about 50 onwards. So about 10 years, we got an insurance policy. For women, aging starts early. And that's why, and if there's a collapse of the upper lower arches, and then there will be as the arches collapse, there'll be, not a happy smile that she would have. So you can think ahead of time.
Thanks.
You see, I'm the one who looks at all these implant cases that's been placed 20 years ago. Okay. And now when they smile because of the labial resorption, because maxillary resorbs, palatally and up. And unfortunately, that happens. And if they have a high smile line, suddenly the implants they have is showing through. It's all dark lines. How do you fix those problems? So it becomes a aesthetic problem, mega aesthetic problem. And we don't realize that the importance of keeping a natural teeth is so much important than just simply trying to take a tooth out for an implant. So when I removed this tooth, this was taken lightly. It took a lot of thought process and consent to do that. And she understood. We couldn't save the tooth anyway. But you could hold the tooth, and many would have mentioned that, I'm sure, it's a temporary anchorage device to put a bracket and line the arches. Yes, of course you could. But then again, I can put a little temporary implant long enough and put a composite and build the same tooth and hook a bracket and develop the arches. That can be done either way. With Invisalign clear technology therapy now, you can do a lot of things. So it's available for the patient. It's just a matter of their priorities and their affordability. And this needs to be explained to the patient.
So you would be highly recommending orthodontic therapy here, right?
Absolutely.
Yeah. I mean, that's the more I look at this case, the more I'm like, well, considering everything you said, the implant will be the last part of the planning.
Last part of planning.
Yeah.
And whenever my sometimes, I know it doesn't sound right, but my calls with me patients, and there's minimal space. They said, "Can you put an implant there?" I said, "Well, no. I see the whole thing. This is a beautiful girl." Da 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 da. And I explain to the patient. And if their general practice is doing orthodontics, I'll send it back to them. And so they never thought of considering orthodontics. Now they're doing orthodontics and leveling along these arches and creating a room that I need to get the best return. And the patient said, "Yeah, I came for an implant, but I got a beautiful smile." That's what it's all about. Any other questions? Philip, are you there? He's probably sleeping. Are you there, Philip? No?
Doctor,
Go ahead.
thank you, Dr. Sarkis and Dr. Mehdi. It was very informative, and I'm lucky to be listening to this. It's very good information. And there's a question for Dr. Mehdi. As you mentioned about calcium hydroxide application as intramedicament, what are the chances of cervical resorption there? And is there a way to avoid it?
From what? Cervical resorption from what?
Because of calcium hydroxide?
Calcium hydroxide doesn't cause cervical resorption.
It,
So cervical resorption is caused by damage to the ligament. Okay.
so, yeah.
So damage to the ligament can happen with severe injuries, periodontal ligament injuries. Yeah, there's no evidence to suggest that cervical resorption is caused by placement of calcium hydroxide, but yes, the periodontal ligament cells are damaged during the initial phase of trauma. So therefore, this is why we recommend the anti-resorptive activity of, or anti-inflammatory activity of things like odontopaste and Litomix, if it's within the first week or so of trauma or on the day of trauma. But other than that, when you place calcium hydroxide a few weeks later, it's not going to make a difference definitely it's not going to cause invasive cervical resorption.
Well, thank you so much.
Yeah. So I think we have to realize what resorption is all about and what you read about the literature. Number one, when you talk invasive cervical resorption, most of the studies were done by Professor Jeffrey Hethersay from Adelaide. He was looking at quite a number of cases. So he was looking at thousands of cases. And he found that things that are linked to invasive cervical resorption are trauma because it's direct damage to the ligament. And also they linked it to orthodontic therapy, periodontal therapy, because you can have some damage to the ligament and you don't know how much damage before the cells of the body start to eat the tooth away. Some people linked it to hydrogen peroxide, and this is used during non-vital bleaching. But when you look at those cases were less than 4% of the thousands of cases that he looked at. And incidentally, those cases were the cases that had trauma that discolored. So the reality is it could be just a chance finding. And we discussed this in, say, Melbourne with Professor Parashos, where he's maybe in a different camp. And we critique things, obviously. And when we see these cases, we're like, every single one of those cases had trauma. So again, we don't recommend heat because it can damage the ligament. It's an extra additional trauma following trauma to the ligament. And of course, if it's discolored, we don't recommend a high percentage or concentration hydrogen peroxide when you do your non-vital bleaching. However, low concentration hydrogen peroxide or no hydrogen peroxide does not really affect the ligament. So it was just an incidental chance finding that those cases that discolored, that had trauma, also needed non-viral bleaching, if you understand what I mean.
Yes, sir. Thank you. Thank you so much.
Maybe I'm just trying to refresh my memory. Was that Lingscott's classification of cervical erosion?
Heather
Heather say.
Yeah.
And he improved on that classification, didn't he? I'm trying to think.
Yeah. So Heather say, like he's the godfather of resorption. He's from Adelaide. You know, we want him to visit Sydney. I want to invite him next year because we lost a year due to COVID. 3 presentations, but we've got him in line for November 21 to travel to Sydney to discuss invasive cervical resorption. So certainly in the initial phase of trauma, whatever you can do that's less destructive to the cells, perineal ligament cells, the better. That's why anti-inflammatory medicaments are used, especially in Australasia, not many other places in the world. But a lot of studies have been done on them, and even researchers in the States are pro anti-inflammatory medicaments such as lenamixin and odontopaste in the initial phases of, early stages of trauma. But once you pass a certain point in trauma, then calcium hydroxide is the antibacterial. You want your antibacterial prior to your anti-inflammatory. Some people mix the two. Okay, so there's a debate about mixing it and whether the anti-inflammatory activity is actually effective enough. So there's literature to suggest it's not. So I'm for anti-inflammatory medicaments and when the initial trauma has occurred. But then after that, I really want my antibacterial efficacy. I really want to heal the lesion. I really want to get everything back. Because I'm losing bone very quickly. I'm losing root structure at times very quickly as well.
See.
Doctor, is there any chance what we can do for internal resorption because of trauma?
Resorption?
Is there, or you have to extract it? That's the only option.
Well, internal resorption of bacterial origin, right? Get in, medicate, it'll stop. Okay, very good prognosis. Often mistakenly, these teeth are pulled out. Okay. Yeah. If you're talking external resorption, that's a different story. So you can have external inflammatory, again, it's bacterial related. But if you've got external invasive cervical resorption, which can happen with crushing injuries, avulsion injuries, other injuries that can damage the ligament at the cervical aspect of the tooth, which is where the stresses are, that's where the weak point is. So with those type of resorptive defects, they can recur, they're difficult to manage. And Heather's say classification 1 or 2 is generally described as cases where you pick up early and you can sort of seal and manage, and you don't need to do complex restorative work for. But once it starts to go down the route, so Heather say class 3, or it starts to just go mishmash right down the route. So if it involves the cervical area or the crestal bone, generally the prognosis for those cases is poor, and it leads to eventual extraction.
Thank you, doctor.
No worries.
So you want the internal resorption to be in the right place, Vivek, that's all.
Yeah, it's got to be in the right place, you're right.
Can I ask a question?
Go ahead, Philip.
I wanted to know if nutrition plays any part in inflammation and infection. Like, would you counsel this patient on what to eat or what to avoid? What about if they are an alcoholic or they abuse drugs?
Sarkis?
All right. And you, Philip, is a question directed towards, for instance, as the alcoholics in terms of causing the loss of balance or in terms of
cost of
healing capability? Sorry?
Outcome for healing?
Yes. Yes. Well, I think if you have an alcoholic who's really an alcoholic, you probably
know. A lot of young people, they party and you'll tell them to be careful. You'll put medication into their roots and,
the patient says she lost her balance, so it could have been a party, could have been taking alcohol. It's very hard to say. They won't tell you the full story. But I guess if someone's an alcoholic, you know they're alcoholic. They have other issues, but
I don't mean just alcohol, but if you've got bone loss, would you counsel the patient how
yeah, in
to
that
eat?
case, when we do the bone graft, we place a patient on vitamin D, very heavy dose of vitamin D.
Vitamin D, magnesium?
Well, you can do all that. Vitamin D especially, vitamin D especially. That's
Right.
very common amongst some of my colleagues who are oromaxillofacial surgeons. They prescribe vitamin D just to improve the bone healing abilities. I think in many ways, I agree, vitamin B complexes, all these are important. But you know, Phil, sometimes we need to think that in Australia, if you eat good food, fresh food, you have all the vitamins. That's just my opinion. You know, I mean, having fish oil and that's great. No?
Yeah, to a certain extent, nutrition helps everything, really. Every type of inflammatory disorder, from endodontic infection to periodontal disease. I mean, the people that can have it are ones that, for whatever reason, they've not controlled their diet. They could have uncontrolled diabetes, smoking habits that are, really out of whack. Any type of smoking is bad, but if that's really uncontrolled, like heavy smoker, then those type of things, as you correctly pointed, do affect the outcome of any inflammatory disorder in the body. And who are we to think that teeth are any different, or the periodontal tissues are any different? They still respond similarly to everything else. So again, yeah, a healthy lifestyle is important for outcome as well.
No,
You ask
thank you.
someone will help.
Ahora miren.
Any questions?
No.
Yes, can you hear me?
Yes, I can. Go ahead.
Hi, Mehdi. This is Amir Ansari from
Hey mate, how are you?
Australia.
Good to hear from you, man. How
I
are you?
actually had a very interesting case right today, and it's very good that I've got you on here and I can ask you the question right now.
Fire ahead.
Okay, well, I had this patient who had a lot of erosion on his lower teeth, had not been to a dentist for the last 18 years. He's a middle-aged man, and he has GRD pretty severe. So he's describing it that he is basically waking up in the middle of night and drinking a little bit of Mylanta and going back to sleep. He hasn't sought any doctor's opinion and specialist advice about it. And he's got these severely eroded sixes, especially in the lowers, where the enamel is totally gone and the dentine is actually a bit cratered. Now on his 4-6, which has no decay, I just noticed on the bite ring that in the furcation area it was a bit translucent, so I took an OPG and there is a big area going all the way to the furcation and the apical area, and the tooth is vital. I put a cold test on it and it's positive, so it was very puzzling for me. I didn't see any cracks in the tooth, or percussion test was slightly positive, but I just could not put it all together what this could be. So I thought I'd just ask your opinion.
So he's obviously overweight, is he?
He is no, he's actually quite built. He's not overweight.
He's not. So he's got a big, thick neck, or no?
Yes, he's got a thick neck, but he's like sort of. He's a person who exercises, but a big size, tall guy, pretty. Muscly kind of guy.
Yeah. So I wouldn't, exclude bruxism and as well as erosion, because most of these patients have an element of blockage somewhere in the respiratory tract. Thick neck style can have a combination of these syndromes. Of course, if they lose weight, it helps. But you're saying that he's relatively not overweight. Is that what you're saying?
No, he's not overweight. He's like,
because I'd be wondering why he's got this, gastric reflux that's severe. Many of them, I'm not all of them, but many of them are overweight. When they lose weight, everything gets better. And less element of apnea, less element of bruxism, less element of erosion. But anyway, the next point I make is Responsive to CO2 pulp testing is neural response, and you can get partial pulpal involvement in these cases, which means that part of the root canal system is due to a crack or due to erosion and bacterial invasion of the root canal system, necrotic, but the other part of the root canal system, for example, distal root fossa, might still have vital tissue. So these kind of cases are interesting cases which puzzle the dentist, where they only rely on a pulp test, right? But however, when you take a radiograph, you see extensive bone loss that could be, you know, as a result of root canal infection if it's just in one area, or a result of a crack. So it could still be endodontic in origin. Of course, I wouldn't disregard periodontal in origin problems as well in patients like this. So sounds to me that you kind of in some of these cases have to reassess by getting into the pulp chamber. And even if you've got partial necrosis, you may need to medicate the root canal as a last resort if you really want, if the patient really wants to save the tooth, and maybe do a periodontal debridement as well, and then see what happens if you don't see a crack. It could be a cracked tooth syndrome from the wear, because even erosion combined with grinding can cause craze lines and things that you can't see. And again, the pulp, remember that the pulp is very resilient. You can have pulp stones, you can have severe bruxism, and you still have vital pulp tissue, or you can have partial necrosis. The most common cases of partial pulp necrosis are lower molar teeth, and they're in cases like this where you've got lots of chronic trauma. So that's low-grade ongoing trauma, but, you know, where it can result in little micro hairline cracks. The pulp, every bit of the pulp, for example, distal root, might still be surviving little bits of the pulp in one root versus the other root, which is fully necrotic and infected. Yeah.
I think
so. This,
yes. Sorry. If I can just say, when you have a erosive diet and many intensities of, I've used the word gnashes tooth together, what happens is if the occlusion is flat, I can understand that, but if the occlusion is more like you have incline or cast incline, as they grind and lock in, that locking effect causes a lot of damage. So for a lot of those patients, what I would do is I will build a canine guidance. So I'll just put composites on palatal with canines, just create an immediate lift off. So do you actually reduce trauma? And they get used to it and actually grind less, because you can just got basically a permanent splint on them. So we also use a concept called dull effect, and I'll talk about that next couple of webinars about how we do conservatively in getting a great result for those patients.
What you find with these patients also, that they could be due to their sleep pattern, unilaterally worse on one side compared to the other side. So if you look at the left,
that's the case. I mean,
you look at the right, it looks a lot worse than the left.
Left is fine. Left has got no areas, nothing, and we're thinking of crowning it. But the right side is got this.
I would say, occlusal splint and tooth mousse inside the splint, whatever, like, you know, Michigan splint or whatever Sarkis thinks with
the splints. With the splints, if patients got an silent gort or a reflux,
they're not going to work.
Big contraindications, because the acid goes traps on the splint and does the worst damage to the upper anterior teeth.
Yeah, so you might have to, I don't know, like sometimes they say tooth mousse and things like that, but
I'll do it. I use that. Use what you can.
Yeah, but that's a very complex case you've got there, Amir.
Yeah, and also just the only other thing I was mentioning is when you on the buccal, obviously probing depth is about 5 millimeters, but it's not communicating with the lesion. So as you're saying, probably maybe a combination. He does have signs of perio as well. The only thing is, with the cracks, is it possible, from what I thought, mainly like if you get a vertical root fracture, usually it's quite quickly, the problem happens quite acutely. Is that
this is more cervical stresses, so it's not a vertical root fracture. Most vertical root fractures are more restorative, like post and previous root fill from apical to coronal direction. These are more cervical stresses. These are sort of, as
It's
I
like
said to
on
you,
hoops,
acid and grinding
hoop.
stresses.
They're called hoop stress. They're called
That's
hoop
right.
stress.
So they happen cervically around the, you know, if you look or if you illuminate. So I highly recommend a trans illuminator because you'll be able to, like, you know, turn the light off and have a look, and you'll probably see lots of craze lines and potentially vertical craze lines around the buccal and the lingual parts of this tooth.
Sure. And basically what you recommend is debridement and then some periodontal debridement.
Medicate and leave. There's nothing wrong with medicating with calcium hydroxide, especially if you don't see any obvious crack within the, you know, they're going down into the furcation or down the root canal system. Just medicate with calcium hydroxide, not odonto paste, and you know, clean it as best as you can. And if you pick up some vital tissue, just remove it, because you know, everything communicates. And then, of course, periodontal debridement, and just watch, because you've got a lot of other things to sort out, the bite and, you know, the reasons for, you know, things need to be under control before definitive restorative treatment. So I agree with Saka. Some of these are the sort of composite build-ups if you can.
Simplify the treatments. So you need to simplify the treatments, and that particular treatment is, I will talk in seminar both in 3 and seminar 4, the reverse smile line, how we fix those cases. It's very straightforward, done in one visit. I mean, here this was done in one visit, not seminar 3, but there are a lot of options, and I think we need to think of what is most important for that particular patient, and how you can get there with least intervention, and get the maximum outcome for that particular patient with the reduced costing. Then you are treating masses of people that will improve your practice profitability and bottom line. The most important thing is you're providing this treatment with minimal intervention. Now, you're not invading biologic tissue. Now, being a prosthetic and implant surgeon, I don't like taking teeth out and putting implants in, because if I can save the tooth, I'm going to save the tooth. Now, you tell me why. Can you someone tell me why we should try to save the tooth before we put implants?
Well, because the implant life itself is limited, so you're trying to get the maximum time before you get the limited lifeline of implant after you're
so what happens? Next one, and then the second part would be, if your implant fails, what happens?
Sorry?
If your implant fails, what happens?
Oh, well, yeah, then you don't really have many options. I guess you have to redo it, or you have to, it becomes much more complicated.
If the implant fails and you could save the tooth, you have to go back in, because you lost a lot of hard and soft tissue, you have to regraft. You just taken 1 year of that patient's life, provided your treatment has been successful.
That's right.
Okay, so you're going to rethink the situation. And even people say, oh, if the lateral's got a very small diameter, you know, you better take it up for an implant. Well, if it's a high smile line, I would hang on lateral patient now. So there's a lot of ways I can control the occlusion and control the forces and control the distribution of forces in my occlusal prescription for my treatment modality, that I can control the forces. And that's very important to accept.
Excellent. Thank you very much.
Yeah, just
Thank
a paper by Pedersen, implant literature, 6 to 10 year survival of implants within, you know, sort of the 80s, not the 95s that someone quoted. And 46% of those implants that remain 6 to 10 years post-operatively have maintenance issues. So these are not all, they don't all lead to failure, but they have maintenance. They're quite high maintenance procedures.
Big maintenance issue. This is what you just mentioned. Thanks, Mehdi, for that. Remember, in my first treatment planning, it's a control phase and maintenance protocol. It starts with the control phase. And this is very adamant. And I'll take a video recording of these patients, because I'm seeing these patients have been screwed up so many times. I need to make sure that they don't think that I'm doing the same thing. So if you can't maintain, you can't keep appointments every initially 3 months. For my hygienist, my therapist will make sure your gums are good and you're looking after your teeth and your implants, whatever. And then you're making a huge investment. You know, it's an expensive treatment prosthetics. So you want to be able to maintain. Just because they pay a lot of money, you know, doesn't mean it's going to work. And that has been made very clear to the patient. That's an important part of the initial assessment and diagnosis. Because you're trying to say, bring them back to reality. And unfortunately, you cannot sell dentistry. You don't sell dentistry. You present dentistry, provided need is there. If they need it, they want it, then they have to own the problem. Provided they own the problem, they're willing to sit on a table for a discussion. And that's how you move forward, provided the biology drives the restorative process. That's a key to the whole dentistry, is the biology drives the restorative process. So do as little damage as you can in that time and reassess. Okay, the biggest problems we have is all on fours, where practitioners are indiscriminately taking teeth out. We look at a case, and we knew we could save this too. We know we can have mobile teeth and do full arch prosthesis and have them maintained for 25, 30 years, provided they are diligent patients. We have non-linear in the studies for 25 years. Huge study, long time. You show me 30 years of implant study, look how many complications there is. The biggest problem with implants is everyone talks how good it is, the first one, next year, and after 5 years, things start to dwindle. When you go 10 years, you see how much bone loss you have. But nobody talks about it. Just going to do a lot of them, done over 4,000 patients, placed implants, and treated more than 1,500 patients on an overall basis, and you see the results. And implants don't preserve bone. They're just actually, they're there as anchorage devices. Your bone decides to resolve, they're going to resolve. You can place some xenografts on minimal, slower soluble xenografts, but that doesn't mean it's going to resolve. It will. It will, and that's where we're going. I think also placing large white platform implants is sometimes unnecessary because bones do restore. We'll talk about in the next few visits. So do please come in and come to the next webinar, which is next week, I believe. So it's lose crown. We'll talk about complex cases. They're all complex cases. And we see how they restore them. We tell you what goes wrong, how things can go wrong, and what happens, and how we manage the problems. And this is the manageable problems.
Thank you, Sarkis, for the invite, and thanks for everyone who is listening. I've got to go and put Celine to bed.
I'd like to
put Celine to bed, baby Celine. So I'm going to be excused if that's okay with you.
Thank you, and thank you, everyone.
Guys. Stay in touch. Stay in touch.
Thank you. We'll close that. Thank you, Mary. Thank you.
Bye. Thank you. Bye.
Any questions? All good? Well,
Thank you, doctor.
Thank you all. Have a good day. Thank you. Have a good day. Thank you.
Thank you. Thank you.
Good night.
Thank you. See you.